Hello everyone, we are here to discuss the AIIMS November 2019 questions. These are recall questions of the exam that has just been conducted this month. These are only based on memory and the language may not be the same, but we've made it as similar as it was to the exam questions. Moving to the first question. Now that's a long one. It also has an image along with it. So let us see what the question is asking us. Here a patient is taking steroids as a treatment for chronic plaque psoriasis. So interestingly, we have been given a diagnosis here. Otherwise they're just asking us diagnosis, but here they have given us a diagnosis and that the patient is taking a treatment in form of steroids for this. The medicine was abruptly withdrawn. Now that is the point to notice here, that the patient abruptly withdraws his medicine, after which he presents with some pustules on the lesion as shown in the image. What is the diagnosis? Now let us look at the image. The image is showing an erythematous lesion with multiple pustules on it. Now if a patient of psoriasis takes steroids, now steroids are a double-edged sword. They are problematic if you take them in a very high dose, and they are problematic if you abruptly withdraw the dose. So in both the situations, steroids can create a hazard for a patient of a chronic plaque psoriasis, which is why they are absolutely contraindicated to be taken either orally or injectably in a patient of psoriasis. The only situation where steroids can be given to a patient is impetigo herpetiformis, where a pregnant lady develops generalized pustular psoriasis. Beyond that, they are not to be used in a patient of psoriasis. So moving back to the question here, if a patient suddenly takes a very high dose or suddenly withdraws the dose of steroid, he can land up into any scenario. Now, the scenarios could either be the patient develops erythroderma or the patient develops pustular psoriasis. These are the two situations that happen when a steroid is abruptly withdrawn. Now, erythroderma, what does erythroderma mean? Erythroderma means more than 90% of the skin is red and scaly. If such a scenario happens, the question will mention as the patient was taking steroids for plaque psoriasis, suddenly withdraws it, patient's entire skin has turned red and there is scaling, patient is having hypothermia and other fluid electrolyte imbalances. So this is what the question will tell you, that a rapidly developing erythema. The point in the question will be a rapidly developing sheet of erythema on the entire body. It may not mention the percentage, it may just say that on the entire body patient has developed an erythema. In that scenario, your answer to such a situation would be erythroderma. Okay? However, if the question mentions, as it has in this one, that after withdrawing the steroids, patient develops multiple pustules on the body which are on the lesion as well as normal skin. In such a situation, your answer would be pustular psoriasis. So these are the two terms that you have to look for in a question where this is being discussed, either sheets of erythema or multiple pustules on the psoriatic lesion. Sometimes there is another word which may be mentioned, that there are lakes of pus formation. These pustular lesions coalesce with each other and it appears as if there are lakes of pus on the body. So either of these two terms help you come to the diagnosis of a complication called as pustular psoriasis in this patient. Now what are the other triggers apart from steroids, which is number one trigger? Sometimes the question may also mention that the patient has applied an Ayurvedic or a herbal medicine, or the patient has applied excessive amounts of coal tar. So these are the other triggers for a similar complication. So this patient was taking steroids and has abruptly withdrawn it. The question could also have been that a patient of chronic plaque psoriasis takes a new ointment from an Ayurvedic or a local quack doctor. He applies it over the entire body. Within 2 to 3 days, he develops pustule over the lesions. What is the diagnosis? So it could come in either way. You have to be aware that these are the two complications. Now, there is another way of looking at this question. If I don't know anything about pustular psoriasis here, I'm not aware of this arising as a complication. I just see this patient as a case of psoriasis who is taking steroids. I don't know the complications of abruptly withdrawing it. I will just see that the patient is taking steroids. Now, why would he or she having pustules? Either it is pustular psoriasis, or it could be a staphylococcal secondary infection on the lesion, or due to the drug, he or she may have a drug reaction, which with such pustular lesions, when a drug reaction happens, is called as acute generalized exanthematous pustulosis, which is also one of the options in the question here. So that is a drug reaction to a drug in which you have pustules developing over the entire body. These are on an erythematous base. So in this situation, how do I arrive at a answer? In staphylococcal infection, the pustules will be on normal skin. Apart from that, patient will have a lot of fever and chills. So in this situation, the image will be that of a septicemia. In pustular psoriasis, as we saw, the pustules were on the psoriatic skin. And in acute generalized exanthematous pustulosis, there will be a definite history of a drug intake after which the lesions have developed. There will be no history of a drug withdrawal here. So that is the point which takes us away from AGEP. Here the drug is being withdrawn and then the lesions are developing. If it is acute generalized exanthematous pustulosis, in that case there will be a definitive history of a new drug which the patient has taken, and within 7 to 10 days of taking that drug, the patient develops multiple pustules over the entire body which are on an erythematous base, and the lesions are predominantly in the flexures. So the lesions have to be flexural, short time between the intake and the appearance of the lesion. Here also the patient will be sick, will have fever, and the absolute neutrophil count of the patient will be high. So these are the other differentials which have to be ruled out in this question. As we see, staph infection we have ruled out, acute exanthematous pustulosis we have ruled out. Now pustular psoriasis is the only one which is the answer here, because subcorneal pustular dermatosis, that entity is a completely different thing altogether. It's a autoimmune vesiculobullous disorder where the patient develops small fluid filled vesicles which may sometimes become turbid due to the presence of neutrophils, but they are not present on an erythematous skin. They are not associated with a history of psoriasis or steroid intake. Rather, being an autoimmune vesicular disorder, if a patient was taking steroids, the subcorneal pustular dermatosis would have actually resolved and not erupted. Okay, so that also rules out the B option, which is SCPD. The only answer to this one is option A, that is pustular psoriasis. I have another image here if you notice, see, this is a case of pustular psoriasis. In this corner to the left, the image shows almost the entire lake of pus which I just told you about. So this is how it looks like. The pustules are present over the erythema of the psoriatic lesion. And this patient here, this is erythroderma. More than 90% of the skin surface area is red and may be associated with scaling. In such a situation, it's very difficult to say that it's a case of psoriasis, but if we have a definitive history of this, we mostly know that it's a complication of the steroid withdrawal. Moving on to question number 2. An adult male presents with flaccid blisters on the trunk and back which take a long time to heal, along with buccal mucosal ulcers. So this is a question which is again giving us a significant amount of hint in the question itself, but it is also giving us some images. So we have to use both of them to arrive at our answer. This is a patient who is an adult, has flaccid blisters on the trunk, has buccal mucosal ulcers. The Zank smear is positive. What is the likely diagnosis? I can tell you the diagnosis right from the text, but let us look at the image. See what the image is giving us. Image is telling us that this is a flaccid bulla, right? A bulla which is like this is a flaccid bulla, and if it was a tense bulla, it would have looked like this. So the image here gives us a flaccid bulla which has slightly turbid fluid in it, but that is not so significant for us. The other image gives us multiple erosions. These are erosions and a small vesicle here. So the gist of the question is the patient has multiple vesicles and flaccid bullae, oral ulcers. This is what the image is also telling us. The Zank smear is positive. I am quite sure that all of you know the answer to this, because in an autoimmune vesicular disorder where you have oral ulcers with flaccid bullae and a positive Zank smear, the only answer to this is pemphigus vulgaris. So that is the only answer possible to such a combination. That would be option B for us, right? Now, if we look at it in a different way, if a patient is just giving us the history of flaccid bullae with a positive Zank smear, in such a situation, the answer could be either pemphigus vulgaris or pemphigus foliaceus. However, in vulgaris, you would have oral ulcers. In foliaceus, there would be no mucosal involvement. So, flaccid bullae can be present in both of them. Zank can be positive in both of them, but it is only vulgaris which has oral or any other mucosal involvement. Looking at the other options, bullous pemphigoid. Bullous pemphigoid would generally be an elderly patient. These would be tense bullae present on an erythematous skin, and there would be a lot of itching. Pruritus is an important feature of bullous pemphigoid. So every question that's talking about BP would, if give you age, would give you more than 50 years of age, then it would mention that the patient has multiple tense fluid-filled bullae present on an urticarial or erythematous base associated with intense pruritus. Zank smear is negative. There are no acantholytic cells in a patient of bullous pemphigoid. However, sometimes in the Zank you may see eosinophils. So that is the only finding in a patient of Zank smear for bullous pemphigoid. Mucosal involvement is rare, it is only seen in 1/3 of patients. So it may not be mentioned in a question of bullous pemphigoid. Alright? Now what is the fourth option? Dermatitis herpetiformis. Dermatitis herpetiformis is also a subepidermal mucosal disorder, happens due to transglutaminase 3 being targeted by the antibodies. Then the patient may have celiac disease associated with it. What are the lesions that look like? The lesions look like papillovesicular, present on the extensors. The question may mention the location as shoulder, upper back, arm, buttocks. These are also intensely itchy, very, very itchy. The point to notice here is that in DH there is no mucosal involvement. So a patient of dermatitis herpetiformis doesn't have mucosal involvement. The Zank would be negative. The biopsy would show papillary tip microabscesses composed of neutrophils. The DIF will show granular IgA deposition, and the drug of choice is dapsone along with cessation of gluten. So that is dermatitis herpetiformis in brief. The answer to this question is B, pemphigus vulgaris. I have an image of the Zank smear also. If they had probably given you the image of the Zank smear rather than the clinical images, it would have looked like this. Look at these two cells here. These are acantholytic cells. They are round with a large nucleus present in between squams. So a normal squam looks somewhat like this. However, an acantholytic cell is perfectly round in order to reduce the surface tension. So this is what you see in the Zank smear of a case of pemphigus vulgaris or fallacious. Both of them would show you this finding. These cells are also called as Zank cells. And another thing that they ask you with it is, Zank cells are which kind of cells? Keratinocyte, melanocyte, Langerhans cell, Merkel cell. These are part of the stratum spinosum. So these are actually keratinocytes. So beware that Zank cells are actually keratinocytes only and not any other type of some cell from the space. So clear to everyone? Great. Moving on to the next question. This is the third question, and these three are image-based questions. So that is how important images are in the exams these days, especially when dermatology is concerned. What is the treatment for this image where you see alopecia with black dots? So the text is only telling us that here you have alopecia with black dots. That is the only hint given in the text, and that the patient is a child. Now let us go and see what the text is telling us. If you look clearly, the text tells you that yes, there is a patch of alopecia. There are black dots visible, plus there is also some broken hair in the lesion. So this is what I gather from the image. Quite clearly, this is a case of tinea capitis. So if it is a case of tinea capitis, I am so happy I have made the diagnosis, but they are asking me the treatment. Now let us look at the treatment. Griseofulvin, fluconazole, nystatin, itraconazole. How would you treat tinea capitis? Treatment of tinea capitis. The treatment of tinea capitis includes certain drugs like griseofulvin, terbinafine, itraconazole. These are the drugs that we mainly use for treating this infection. Griseofulvin, the dose is also asked, it's 15 to 20 mg per kg per day. Terbinafine is around 5 mg per kg per day, and so is itraconazole. These are in total given for a duration of 4 to 6 weeks. So this is how we treat tinea capitis. But in this question, we have both griseofulvin and itraconazole in the option. So that is what makes it a little tricky. But if we see as the first line drug, according to British Academy of Dermatology, the first line drugs are griseofulvin and terbinafine. If a patient is not responding to griseofulvin or terbinafine, that is when you go to itraconazole. So itraconazole is a second line management for patients who do not respond to these two first line agents. So in this question, my answer would be option A, that is griseofulvin, because this is the first line for the management of tinea capitis in a child. It is completely safe, doesn't cause any adverse effects, has been used for a long time with well documented studies. So this is the first line drug for a child who is a case of tinea capitis. I hope I am clear to everyone. Do not get confused between these two options. Now I just have a list of what are the types of tinea capitis just as a revision. If it is a black dot tinea capitis, it's a case of endothrix caused by the trichophyton species. You also have to remember which dermatophyte species causes which type of tinea capitis. So the black dot is caused by the trichophyton, while the grey patch, which is an ectothrix, is caused by the microsporum species. So these are the two different types of ecto and endo which you have to remember. With this grey patch, there is a mnemonic by the name GMC. G is for grey patch, M is for microsporum, and C is for EC, Kasi, ectothrix. So that is how you can remember GMC, grey patch, microsporum, ectothrix. And this is BNT, black dot, endothrix, trichophyton. So BNT and GMC. One more question that comes with grey patch is its finding on wood slab, pale green fluorescence on wood slab. Only the microsporum species are positive on wood slab, and that is why you would only see it positive in a case of grey patch, pale green appearance. Chirion could be caused by any of the zoophilic species. We don't need to remember the species for chirion. For favus, yes, they ask you. It is Trichophyton schonloni. For favus, the species is important, Trichophyton schonloni. And one more question with favus is scutula, which is the C-shaped crust at the hair root on the scalp. So scutula and the species are two questions from favus, while the species and the type of infection come in black dot and grey patch. With chirion, it's mostly a descriptive question. Erythematous boggy swelling studded with pustules with easily pluckable hair, occipital lymphadenopathy. What is the diagnosis? With all these tinea capitis, the two questions apart from the diagnosis that come are either what is the next investigation or what is the treatment. So what is the next investigation? In any fungal infection, the next investigation is always KOH scraping. So in this same question, if they were not asking me the treatment and they were asking me the next investigation, the answer would have been a KOH scraping and examination. If they are asking me the treatment is griseofulvin. pulvin. I hope I am clear to all of you. I have just included some more images here. See, this is how black dot looks like. In a case of tinea capitis, always there will be some broken hair scaling vesicles on the lesion. So in black dot also I am seeing black dots and broken hair. In grey patch also I am seeing broken hair and some scaling. In cheiron, it is the description that I just gave you: erythematous swelling, pustules, easily pluckable hair. So that will help you solve all questions related to tinea capitis. Moving on to the next question. Which of these is not a maculopapular rash? This is an easy one. Let us look at the options: measles, rubella, dengue, zoster. So if I have to divide the viral rash into these groupings, either it's a maculopapular rash or it is a vesicular rash. So the maculopapular rash is going to come in measles, rubella. Dengue will have a maculopapular rash in the initial phase and a petechial rash later when the platelet count goes down. So it is only in the initial phase of dengue that I may have a maculopapular rash. That you can also see in the early stage of the HIV infection when there is a viremia. Then erythema, infectiosum, and roseola infantum, all these show a maculopapular rash. Now, where do I see a vesicular rash? I see a vesicular rash when it is herpes labialis or herpes gingivostomatitis, then genital herpes, varicella, and zoster. So varicella and zoster are the two other conditions caused by the same virus which cause a vesicular rash. When it is widespread, first episode, it is varicella. When it is a radicular dermatomal distribution, then it is a zoster. So this allows us to make the diagnosis of viral rash. Moving back to the question, measles, as I just told you, rubella and dengue, all three will fall in this category, while zoster falls in this category. So the answer to this question is option D. How does the viral zoster rash look like? That is how zoster looks like. If you notice the image here, the image has multiple vesicles grouped on an erythematous base present along a dermatomal pattern. So this is the viral vesicular rash that you see in zoster. So this will even give you a visual memory in case you get such a question. So moving on to question number 8, paucibacillary leprosy treatment. Now this looks like a very simple question. We all know what leprosy treatment is. This is leprosy treatment. I have been reading it since second year. PB is rifampicin dapsone given for 6 packs, which is 6 months, and then MB is rifampicin clofazimine dapsone given for 12 months. Why are they asking me such a question? The answer should be very easily that the paucibacillary leprosy treatment is 2 drugs for 6 months, right? Shouldn't this be my answer? No. That is where this question is very important. This question is very important. Why? Because there has been a recent change in the WHO MB-MDT for leprosy. And why has this question been asked in the AIIMS? Because AIIMS was the first institution in the entire country to implement this regimen. Because it was adopted by the NLE later, so in all the other hospitals it has come later, but the AIIMS was the first to take it, so they have very conveniently asked you this question in the next possible exam. Now, what is the new recommendation from the WHO, from the MDT? The new recommendation goes like both PB and MB, both of these receive the same drugs. Both of these receive the same drugs, that is monthly rifampicin 600 mg, monthly clofazimine 300 mg, plus a daily clofazimine 100 and dapsone 100. So RCD, that is the three drugs, are now common to both PB and MB. Okay, they are common. It is not like before. The difference is that PB patients will get this treatment for 6 months, while the MB patients get this treatment for 12 months. Okay? So, this is wrong now. This is obsolete. I urge you all to note down this difference. For PB patient, he will take RCD, that is 3 drugs now for 6 months, while a MB patient will also take RCD, that is 3 drugs but for 12 months. I hope I am making it clear to all of you. This is a very, very significant change that has come in the management of leprosy. Okay? The next question is on an association. Which of the following are associated? Melasma and malignant melanoma, vitiligo and malignant metabolic syndrome, psoriasis and metabolic syndrome, lichen planus and malignant melanoma. So they have actually put in a good amount of mind forming this question. How will you think of it? With malignant melanoma, and metabolic syndrome, they have given us 2 options each. With malignant melanoma, either it is melasma or lichen planus. With metabolic syndrome, it's either the option of vitiligo or psoriasis. So we have to choose between one of them. Now, melasma is a situation where there is pigmentation. With lichen planus also, it heals with pigmentation. So even though both of them are black, but they do not have any association whatsoever with malignant melanoma. So this is not an association. This is not an association. So these 2 options are wrong. Clear? Now we move to the next group. The next group is that of metabolic syndrome. In this, we have either vitiligo or psoriasis. Now, it's quite an old scientific research now, and over these years, it has been firmly established that psoriasis has not just a cutaneous inflammation, but psoriasis also has a component of systemic inflammation. That means the inflammatory mediators are roaming around in our entire body, affecting all our organ systems, out of which the most commonly affected organ system is CVS. So patients of psoriasis have increased risk of coronary events. Why? Because there is increased risk of atherosclerosis due to the oxidative and the inflammatory damage of these interleukins on the walls of the arteries. So these patients have increased risk of atherosclerosis, leading to increased coronary events as well as cerebrovascular events. Apart from this, the patients of psoriasis also have increased risk of metabolic syndrome. They tend to be obese, have hypertension, diabetes, increased uric acid levels, increased cholesterol levels, again due to the component of systemic inflammation, which leads to all these factors, thereby leading to a constellation of metabolic syndrome. So psoriasis, if they ask you association with cardiac events, cerebrovascular, diabetes, hypertension, metabolic syndrome, yes, psoriasis has an association with all of them. Okay, so the answer to this question here is option C, which is psoriasis and metabolic syndrome. I hope all of you have understood this. If you go back and read the pathology of these atherosclerosis and other events, you will see that the inflammatory component is very important, and that is why psoriasis has such an association with metabolic syndrome. As far as the associations of vitiligo are concerned, with vitiligo mostly you are asked association with Hashimoto's thyroiditis. It is also the most common endocrine disorder associated with vitiligo. Then you may get a question on diabetes mellitus type 1. Why? Because one autoimmune disease always has a tendency to be associated with other autoimmune diseases, and sometimes the option is alopecia areata. So all these Th1 type of autoimmune disorders can be associated with vitiligo, and that is where most of the questions with respect to association of vitiligo are there in your text. With respect to malignant melanoma, if there are any associations, they are mostly with the pre-malignant lesions. The pre-malignant here are giant congenital melanocytic nevus, then the dysplastic nevus and lentigenes. These are the associations that may be mentioned with respect to malignant melanoma. Okay? So I hope I am clear and you know why option C is the answer to this question. Moving on to question number 10. This is a question based on the new format which has recently been introduced in the AIIMS exam. Match the following. They are being very smart. You know, with these kind of associations and match the following questions, they are not just testing whether you know the inclusion body with molluscum. They are testing whether you know all the inclusion bodies with all these 5 options. So, you know, they are trying to gauge even more of how much knowledge do you exactly have. So, you know, they're moving one step ahead of the students here. Very, very well ahead. Before we solve this question, I will just give you a list of the viral inclusion bodies which will make you reach the answer quite easily. When we talk about viral inclusion bodies, we always divide them either into this you must have studied in microbiology also. We divide them either into intracytoplasmic or intranuclear. When we talk about intracytoplasmic, there are certain bodies which are important for the questions. Number 1, Negri bodies. Number 2, guarneri bodies. 3, Paschen bodies. 4th is Bollinger bodies, and 5th is Borel bodies. Negri bodies, where are Negri bodies seen? Negri bodies are seen in a patient of rabies. Guarneri bodies are seen in a disease which is smallpox caused by the vaccinia virus. Paschen bodies are again seen in smallpox caused by the same virus. Bollinger bodies in fowl pox caused by the pox virus, and Borel bodies are again seen in fowl pox. So what you have to remember: Negri for rabies, Guarneri and Paschen smallpox, Bollinger and Borel fowl pox. So B, B, F, Bollinger, Borel, fowl pox, while G, P, S, Guarneri, Paschen, smallpox. These are the intracytoplasmic inclusion bodies in viral diseases. Apart from these, we have certain intranuclear inclusion bodies. In the intranuclear inclusion bodies, it depends on 2 criteria, whether they are acidophilic or basophilic. The acidophilic are your Cowdery type A and Cowdery type B. A is found in varicella, herpes simplex and yellow fever. So herpes, yellow fever and varicella have Cowdery type A acidophilic bodies, while the Cowdery type B acidophilic are seen in poliovirus, and Cowdery type B basophilic are seen in adenovirus and CMV virus. Clear to everyone? These CMV virus inclusion bodies are also called as AIIMS bodies. So the another name for the inclusion bodies seen with a cytomegalovirus infection are AIIMS bodies. Then one more body that you are supposed to remember is the Henderson Peterson inclusion bodies, which are also the largest inclusion bodies seen with mollusky pox virus infection causing molluscum contagiosum. Clear to everyone? Yes? Great. Then one more is the one with measles. There it is actually the name of the cells which are called as Warthin Finkelday cells. Right? Clear? I know all this thing is confusing. It's very confusing, but you have to remember there's one mnemonic with it. That mnemonic for intranuclear inclusion bodies is a very happy family. V is for varicella, H is herpes simplex virus, A is adenovirus, P for polio, C for CMV, and Y for yellow fever. This is Cowdery type A, B, 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 A. So this B is also called as alveoli body. That's it. So this is how you can remember. VAA, BBB, A. Coming back to the question here, let us see what are they asking us. Molluscum contagiosum, right in front of us. Henderson-Peterson bodies. Papilloma virus, right in front of us. Coilocytes. These are the vacuolated cells which are seen in the epidermis infected by the human papilloma virus. The BK polyoma virus is the decoy cells. Vaccinia is the guarneri bodies, while CMV is the alveoli. So the option here is 1A, 2B, 3C, 4E and 5D. So that is how this question is solved. They can ask you any and every viral inclusion body or any typical cells which are seen in typical infections. So that is a list which you don't have to remember now for just one question. You have to remember that list where 5 of them can be asked in the same time. That is where they are getting smarter than us. Now, the last image-based question for this test is this one. Deficiency of which vitamin causes this disease? So what do you see here? What is it that you are seeing here? In this image, I see that there is a scaly hyperpigmented rash present in the neck region. Now this is such a classic question which is asked so many times in the image based questions that I am sure you all have seen this image at least once while you are studying, because even if you go through the repeat questions of the last 2 to 3 years of these exams, you will find more than one question which has a similar image given. This is such an important and such a frequently asked image based question. Just by looking at this rash in the neck region, you really cannot make a diagnosis unless you know what it looks like. This looks like a necklace. Where do you see such kind of a necklace? You see such kind of a necklace as Castle necklace. This is her classic finding of a disease called as Pellagra. So this is a classic finding of Pellagra which is due to deficiency of vitamin B3, that is niacin. This is deficiency of vitamin B3. How does this present as? This present as diarrhea, dermatitis and dementia. Pellagra always starts in the GIT. So this is the first thing that you notice. The patient almost always complains of the beginning with the diarrhea, after which he develops the dermatitis. The rash is present in photodistribution. So it is the photodistributed sites which mostly have this rash, and it is an acute hyperpigmented scaly rash. What are the two named features? The named features are number 1, Castle necklace, which you see in the neck region as given in the photo there, and number 2 is the gauntlet sign which you see on the dorsum of the hand. Gauntlet is those steel kind of gloves that villains in the previous movies used to wear. So that's the gauntlet sign, and this is the Castle necklace. Two named features of a pellagra rash. Dementia comes later, and this is almost always followed by death if untreated. So these are the 4 Ds of pellagra. Apart from this, what you should know? You should know who, as increased chance of developing pellagra. Increased chance is seen in people who are predominantly corn eaters, then alcoholics, and people who are taking certain drugs that increase the metabolism of niacin. What is the treatment? Treatment is give a dose of niacin or nicotinic acid 500 mg thrice daily. That is the treatment. Pellagra is a very important question, and so are these deficiencies which are caused by these different vitamins. They can be asked both in text and image. Let us look at the options here. Riboflavin. Riboflavin is vitamin B2. Deficiency of riboflavin causes angular cheilitis and corneal vascularization. Niacin deficiency causes pellagra. Pyridoxine deficiency causes neuropathy, and biotin deficiency causes neuropathy. Pyridoxine deficiency is generally seen in patients of ATT who are taking isoniazid. Clear? With biotin, it is neuropathy generally seen in the elderly. So I am sure all of you have understood the questions and their answers. In case you still have any doubts, you can always get back to me on my email ID. I will be more than happy to help you at this time. It's APALLAVI99@gmail.com. All the best for your exams. Do well, think well. The answers are not always that difficult. Think of common things first. Thank you.